Thank you, Jenny, for having me, and thank you for putting it on the same day as the muscle contest, because I don't have to travel to a different location. I can just go right there afterward. And I'm on at 3, in case you're wondering. So today, we're going to talk about the myeloma toolbox, focusing first actually on cell mods, but then also moving into some targeted therapies and how we might be thinking about personalizing care for myeloma using maybe a little bit more of a precision medicine approach. And some of the things that Jenny was talking about with MyelomaTree Cure Hub, I think these are going to fit in nicely as we start to aggregate data from patients, both from a clinical standpoint and from a genomic standpoint, so we can work together and find new targets for myeloma, as well as how to better sequence our treatment options for patients. These are some disclosures. So first we're going to talk about cell mods, which there's a little bit of controversy as to whether these are the new IMiD on the block or a different drug class entirely. We'll talk about genomically targeted therapy in multiple myeloma, and then we're going to talk about how we can use some of our newer technologies, how there's an evolving strategy in myeloma to better understand the patient's genome and then use it to inform our treatment decisions. There are a lot of other things that could fit into this idea of personalizing care for multiple myeloma that we just won't have the time to talk about, but things like MRD adaptive treatment strategies, risk-tailored treatment strategies, and other personalization that don't make it to this talk but are certainly relevant and may come up in the Q&A later. So let's talk about cell mods first, and we should understand a little bit of the history and the mechanisms of immunomodulatory drugs, or what we call IMiDs. And these are the workhorses of myeloma in the current state. And this is a little bit of a chemistry class. There will be an exam at the end, so just make sure you're paying attention. I'm sure many of you are familiar with a lot of these IMiDs, immunomodulatory drugs, lenalidomide, pomalidomide, maybe less so thalidomide. And probably for the first 10 or so years, we didn't really understand how they worked or why they worked. We just knew they worked. They kind of do a little bit of everything. And you can sprinkle it on anything too. You can combine it with a bunch of the different myeloma drugs that we use. They affect the tumor microenvironment. They lead to immune activation. They target the machinery of the myeloma directly, but we didn't really clearly understand why. So how can we design better drugs if we don't know what they're doing? So over the course of the next 10 to 20 years, they started to uncover what the mechanisms are. And so how these IMiDs act is kind of like what they use the term molecular glue. So there's this, I'm going to work my way backwards here, but there's this structure inside all cells called the proteasome. Think of it as the garbage disposal of the junk that you find in the cell. So all of these things that the cell has too much of or shouldn't have, the proteasome is going to degrade them. What they discovered is that lenalidomide or Revlimid and all of these IMiDs bind to this thing called the cereblon E3 ligase. And what that is this thing that helps target things to go in the garbage disposal. And when it binds to this cereblon thing, it causes it to identify new garbage. We call those neosubstrates, or the S here. But it's finding new garbage that myeloma cells actually normally use to function, to live, to exist, to move, to become cancerous. So now this thing that identifies the garbage now identifies these things that myeloma uses and throws it in the garbage disposal, so the myeloma can't survive. And so we knew that these things were important, but we didn't really know which garbage was the most important until more recently. So just within like the past 10 years, these two, what we call transcription factors, these are very important things for the myeloma to develop all of its abilities to be cancer. These things called Ikaros and Ilos, these were really the most specific, the most important garbage in the myeloma cell that these immunomodulatory drugs, the IMiDs, lenalidomide and pomalidomide, were identifying and throwing in the garbage. So now that we know the mechanism, now that we know which of this garbage is most important to the myeloma, now able to design drugs that specifically target that, so that not only might they be more effective at killing myeloma, but they might also reduce some of the side effects that people experience from the drugs from before. We're still waiting to see if that's the case, but that's the idea, that if we can design the drugs to specifically go after these things and nothing else, that perhaps these drugs are going to be better and easier on patients. So this has created a whole new class of drugs called cell mods, and we'll go specifically into that. The two cell mods that are being developed now, one is called iberdomide and one is called mezigdomide, and this is mezigdomide right here. What happens is when these cell mods lead to the destruction of these two things, Ikaros and Aiolos, it does a couple of different things. It kills the myeloma directly, and it activates the immune system to go after the myeloma. So when we talk in the context of all of these new cool immunotherapies coming out, perhaps we can then use these drugs in combination or as maintenance afterward in order to continue to boost the effect of the immune system against the myeloma. So here's where the chemistry class comes in, but essentially the mezigdomide and iberdomide are these cell mods. They're called cereblon E3 ligase modulators, specifically designed to go after that garbage, those two targets that are so vital to the myeloma cell. So if we compare thalidomide and pomalidomide, kind of the earlier versions of those IMiDs, you can see that this ring that they add, this whole thing that they added is way more complex because they wanted to really maximize the effect on those two targets. And what that leads to is this cereblon, this one thing that it's targeting, the thing that throws stuff in the garbage disposal, is, in the case of iberdomide, it's active half the time. In the case of mezigdomide, it's active all the time, 100%. Compare that to pomalidomide, which is a pretty good drug and used pretty commonly. That's only in the active state 20% of the time. So these are much more potent at getting after those two targets, the Ikaros and Aiolos, with the hope that they're not finding any other garbage, just those two things, and that may make these drugs more easily tolerated. It leads to things being rapidly degraded, and they work together in combination with a lot of the myeloma therapies that we already have. The proteasome inhibitors such as bortezomib and carfilzomib, the monoclonal antibodies such as daratumumab and elotuzumab, and we'll go through a little bit of the data that's going to be on the test later, but we saw it both in preclinical studies where we looked at it in cell lines and mouse models, and also what we're seeing in the early phase clinical trials that have been done and some of the newer clinical trials that are going to be on, or the larger clinical trials that are ongoing. So the first combination was, and I'm going to focus a little bit more on mezigdomide here as opposed to iberdomide, just in the interest of time, but both of them are in a whole host of combination studies right now, and both likely will have a role in the treatment of myeloma as they eventually garner their approvals. But when it comes to mezigdomide, the first combination it was with dexamethasone alone, with the steroid. And even in a pretty heavily pretreated group of patients who had a lot of prior therapies, including bispecific antibodies or CAR T-cell therapy, and many of whom had what we call extramedullary disease, or tumors that formed outside of the bone, there still was a 50% response rate, and the median duration of response was about 8 months. Certainly not the best we've seen in some of these later treatments, but promising, especially as we think about using them in combination with a lot of the other drugs that we have. One of the things that we have to look out for as far as side effects with this class of drugs, most prominently is neutropenia, or low neutrophil count. It's a type of white blood cell. It's very important. And part of this is actually an on-target effect of this class of drugs, so that Ikaros and Aiolos, those two transcription factors that we were talking about, they're actually really important in the development and maturation of neutrophils. So it wasn't unexpected that if you're targeting that more heavily, you will see more of that neutropenia. The good thing is it didn't translate as much as it was expected to risks of infections, and it was also very manageable with the use of what we call growth factors, things like Neupogen and Neulasta. Both in the early, what we call preclinical, or the before it got to clinical studies, and in clinical trials, there has been a lot of excitement with the combination with proteasome inhibitors, much in the way that we use bortezomib and carfilzomib in combination with pomalidomide and lenalidomide. It seems that you can do so with this new class of drugs as well, even in patients who have been treated with a lot of drugs before. So in a couple of phase 2 trials, mezigdomide in combination with bortezomib, with response rates near 90%, in combination with carfilzomib. Similarly, the duration of response rivaling that of what had been seen with CAR T-cell therapy, close to a year, and the safety profile didn't really exceed that of what had been seen in just the mezigdomide dexamethasone alone. So the neutropenia being the thing that we watch out for the most. There are a couple of ongoing phase 3 trials where it's looking at different combinations with bortezomib or carfilzomib compared to some of the standard combinations that are being used, and this is going to be used to try and get approval through the FDA. As I mentioned, there's combination treatments with monoclonal antibodies. The most one that we think of the most is the CD38 targeting one of daratumumab, and this was used in combination with daratumumab in a phase 2 trial in dexamethasone. We saw they looked at it in a couple of different dosing cohorts with a little bit of differences, but in the best one, close to 90% response rate. And what they noticed as they did some of the correlative studies from this is that it has a positive effect on the immune system, the part of it that is being harnessed by the daratumumab. So there's a little bit of synergy, or kind of a 1 + 1 = 3 effect when they're used together. And this is also being looked at in phase 3 clinical trials with mezigdomide and with iberdomide in combination with daratumumab. And I talked about things in combination, but there actually was a small cohort of patients where we looked at it as a monotherapy without any other combination partner. And it had activity even in this case, and it was used, and looking at some of the correlatives, had a beneficial effect on the immune system as well. So this kind of positions it, both mezigdomide and also iberdomide, possibly in the maintenance setting. We're looking at it in a clinical trial up at City of Hope as a maintenance after a certain CAR T-cell therapy, because it has a positive effect on the immune system, and the CAR T-cell is an immunotherapy. And it also has a impact on keeping myeloma levels low. So with it as a monotherapy and some of the data that we have available, suggesting that it could be positioned in combinations with immunotherapies or as a maintenance therapy thereafter. A study that was published or presented at ASH this past year was starting to investigate this idea of combining it with more of a personalized therapy approach. So this phase 1 and 2 study was looking at 3 different combinations with mezigdomide. One was with a drug that's approved for follicular lymphoma called tazemetostat. Another was a BET inhibitor. Another is a drug that's used for melanoma. And this was based on some preclinical work suggesting that they work well in combination. And those 3 agents I was talking about, we can look at a patient's mutation profile or look at their gene expression and see, would that be an ideal personalized therapy for them? And now where they just looked at it in kind of all comers at this point, eventually they're planning on using that personalized, molecularly targeted approach to put patients into these different combination cohorts and see if they can boost the effectiveness of both drugs together in patients where it's designed specifically for them. and this is going to kind of dovetail into my next portion of the talk, is molecularly profiling and using targeted personal treatments. But as we wrap up what we're talking about with cell mods, they are, as opposed to the immunomodulatory drugs, as opposed to lenalidomide and pomalidomide, which we found out the mechanism after we started using them, these drugs were specifically designed to go after that target in the myeloma, the Ikaros and the Aiolos transcription factors, with the idea being that they could be designed to be more potent and hopefully have less side effects. And we'll find out from those ongoing phase 3 trials if that indeed is the case. There's synergy or when we use them in combination, they seem to work even better than expected with the existing classes of drugs that we have for multiple myeloma, and these combinations are currently being tested. Even as a single agent, it may have a role as a maintenance, either post-transplant or post-CAR T, and we're looking at combining them with other targeted agents to see if it can boost the effect in patients that are specifically selected for drugs that will likely work in that group of patients. And as I mentioned, neutropenia is an on-target effect, side effect, but one that we have been okay with managing so far. So let's move into the next part of the talk, which is talking about personalizing care for patients with multiple myeloma. I was thinking of this in the context of how we use patients' molecular and genetic data to inform treatment decisions, but this complements exactly what Jenny and HealthTree are doing, which is to use the clinical information and some of the genetic information to identify personalized treatment in clinical trials as well. And so hopefully as this becomes more widely used, we can put all of the forces together and provide patients really personalized treatment options. So when we think about genomically targeted therapy, we're either identifying a unique mutation in a patient's myeloma, in a patient's myeloma genome, or an abnormality in how their genes are expressed in a subgroup of patients, and then taking a drug that we think is going to be exceptionally effective in that group and using it. The problem with myeloma is, as compared to a lot of other cancers, such as acute myeloid leukemia and certain types of lung cancers, it's not as clear-cut as saying one mutation is causing all of these problems. Yes, the mutations are important, and yes, they have some impact in driving the myeloma, but there's a lot of other issues going on. The myeloma unpackaging of all of these genetics, what we call the epigenetics, and how the big changes in the chromosomes or the packaging of the DNA occur, it's much more complicated than just one mutation. And many of the mutations that we know about are not yet targetable. So we do have a lot of work in the myeloma field to better understand the genetic abnormalities in myeloma patients specifically, and seeing if we can identify targets and new targets. At the moment, there really is only one molecularly targeted treatment recommendation for a certain subgroup of patients based on a genetic abnormality. And this doesn't even yet have an FDA approval. This is just guideline recommended. And specifically, this is the use of venetoclax-containing regimens in patients who have an 1114 translocation. We'll go into a little bit of that right here. So 1114 translocation is where a piece of the 11th chromosome and a piece of the 14th chromosome, these are big packaging of the DNA, they break apart and then rejoin together. This is in that group of patients, which makes about 10 to 20% of myeloma patients, what initially drives that myeloma. And it behaves differently. The 1114 translocation behaves a little bit differently than other myelomas. It tends to be a little bit stubborn. It tends to the myeloma cells look smaller. Sometimes they'll lead to less secretion of the myeloma proteins that we're used to following. It is associated with things like amyloidosis and plasma cell leukemia, but not in all patients who have this translocation. But what it also has is a unique Achilles heel or susceptibility to a certain class of drugs. We call them BCL2 inhibitors. And that's because what BCL2 is something that keeps cells alive. Usually there's a balance between BCL2 and another protein, but for whatever reason, myeloma in this group relies heavily on BCL2. So we can use a class of drugs potentially to target that and kill that myeloma. There have been a number of studies looking at venetoclax, which is the only approved BCL2 inhibitor at this time, to see if it's effective in this group of patients. There was a study combining with dexamethasone, which a phase 3 study comparing it to pomalidomide and dexamethasone. And some argue that it was the statistical design of the study, but it ended up not being a positive study, although patients did tend to have deeper responses, and there was a trend toward improved survival in patients who were on the venetoclax arm. There was a phase 3 trial looking at all myeloma patients using venetoclax plus bortezomib versus bortezomib and dex alone. This is an important point. When they looked at it in its entirety, which included patients with 11;14 translocation and not 11;14 translocation, the venetoclax actually had a negative effect on survival and an increased risk of infection. So patients who don't have an 11;14 translocation should not get venetoclax, and that is one point worth hammering home. But when they looked at the 11;14 translocation group of patients, they did have better outcomes. They had longer remissions, longer survival, and the infection risk was manageable. So that's why for that specific group of patients, venetoclax is a potential option in combination regimens. There are a couple of other smaller studies that looked at venetoclax and other combinations that were promising as well. Currently, there's a newer BCL2 inhibitor, something called sonrotoclax, which is in clinical trials initially with just dexamethasone alone, and this was presented at ASH a couple of years ago, also being used in combination with other myeloma agents, and it's looking to have very promising responses, but once again, only for that group of patients who have the 11;14 translocation. So something that is uniquely targeted to a specific genomic abnormality. But that's kind of it right now. There really needs to be a lot of work in order to identify these precision targets for patients. There have been other studies that have been done looking at other specific mutations. Sorry if this looks pretty small, but this one was a combination trial using in patients who had a relatively rare mutation in myeloma called BRAF. It's much more common in things like melanoma, but they use some of the drugs that target that specific pathway from melanoma in patients who had multiple myeloma with this specific mutation, and they saw very promising responses. It was just a very small study. And then the Multiple Myeloma Research Foundation also recently concluded a study where they did sequencing on the patient's genome, and if they identified a targetable pathway or mutation, they would then put them in a different arm of the trial, specifically using drugs that would inhibit that pathway. And we're waiting on kind of the final results of that to see how effective that mechanism is. But I would say that the publicity of myeloma treatments has really shifted into the immunotherapy and cellular therapy, or CAR T space, more recently. A lot of the focus has been on these dramatic outcomes that we've seen, as Dr. Costello talked about just beforehand, looking at these 90+% response rates with CAR T cells. And so it kind of begs the question, is that going to shift the focus so that we're not going to focus on personalized or precision medicine in multiple myeloma? And that, because as it pertains to those CAR T cells and those immunotherapies, those targets are expressed on pretty much all myeloma cells. It's not really a precision focus. And if we look at the approvals that we've had in the past 5 years or so, they've really been these immunotherapies and CAR T-cell therapies. But I would argue that they can be used hand in hand. We have the ability to use patient-specific genomic data to help inform our treatments with specific drug classes, but also to inform our treatments using these CAR T-cell and bispecific therapies. And so I'll go into what I mean about that. So these slides are courtesy of Dr. Jonathan Keats, and he's the scientific director at City of Hope, as well as the Genomics Institute. And what we're looking at is some data that's been looking at the mutation profiles of patients who have specific mutations after getting different bispecific antibodies. We kind of have been asking the question, if a patient gets one BCMA targeting bispecific antibody, can they get another one at a different time? And the answer is it depends. And how we're going to understand that is by sequencing their myeloma genome after they get one and looking to see if the information we get suggests that another one will be able to target it even if the original one has a mutation that we can't use. So basically just showing that patients exposed to one type of BCMA bispecific antibody, depending on the mutation that they get, may still respond to others. Right now, in order to understand patients' genomic information, we're using a test that was really developed in the 1990s, something called FISH, fluorescence in situ hybridization. And that gives us a very small fragments of the whole picture. So we can only target certain genomic or genetic abnormalities in a patient. That 1114 translocation, the other translocations, 17p deletion, these are usually just the things that we talk about when we're talking about FISH results. But there's so much more out there. And when we talk about your entire genome, the entire sequence of all of the DNA in each of your myeloma cells. So using something called whole genome sequencing is really going to change our focus on personalizing and creating precision medicine strategies for multiple myeloma. This is a plot of all of the DNA in a myeloma cell and all of the mutations and interactions between chromosomes so we can get a whole big picture relatively simply. We're doing it for other cancers, and it's really going to become hopefully clinically available within the next year at most places. It's a simple, comprehensive, and very straightforward test. It gives all of the known genetic mechanisms, the big chromosome breaks, as well as the individual mutations. You can pick it all up in that one test. We can identify and hopefully discover new mutations, mechanisms of resistance, and new targets for targeted therapies. And importantly, the International Myeloma Society and the IMWG are in the process of publishing new guidelines in how we talk about high-risk myeloma. And one of their main recommendations is moving away from FISH testing and moving toward genetic sequencing, whole genome sequencing, or targeted, what we call next-generation sequencing, because this is going to provide much more detail on the mutations and the big genetic events than what the current strategy of FISH testing can do. And also they're recommending that at different junctures, at different time points in myeloma treatment, not just at diagnosis, but also at choosing new treatments or disease progression, that this be done again to identify if new mutations or new genetic events have occurred. So this is a specific patient example where this actually played a role. So this was a patient that I was involved in the treatment of, and they had gone through many different therapies before. Most recently, he did have teclistamab, a BCMA binding bispecific antibody. So one of the questions was, if we were to proceed with something like a CAR T therapy, which he hadn't had, would we expect it to work? And then secondly, if they were to if they needed a different option, what option would that be? So they did a genetic analysis, whole genome sequencing of the myeloma, and unfortunately what was identified was that the BCMA target on both copies of the chromosome that this patient had was lost. So using a BCMA targeting CAR T cell in this particular patient would have spent a lot of his time without really providing any potential activity. So it informed this treatment specifically for this patient. Not only did it tell us that the CAR T wouldn't necessarily work, but it gave us an idea of options for what might. It identified that this patient had 3 copies of the target of what's called the investigational bispecific antibody cevostamab, and then 2 copies of GPRC5D, which is a target for talquetamab. Both at the time were in clinical trials, and fortunately, this patient was eligible for both. We went with the cevostamab, which, because of the fact that there were 3 copies of it, 3 targets, and he actually achieved a complete response that remained durable for a while. So this was an example of personalized treatment based on the genetic sequencing at a specific time point that informed not only which treatment wouldn't work, but which treatment potentially would. And so this was a pretty good case study that we're hoping becomes the mainstay of myeloma treatment in the not too distant future. At the Genomics Institute, Dr. Keats, and across many labs as well, they're working on making very fast turnaround times for genetic sequencing, where we can specifically target the myeloma cells out of a bone marrow biopsy or another type of biopsy, run it through this genetic testing, and return a report with actionable items within 48 hours. So this will really change the dynamic and the personalization of myeloma treatment in the near future. So currently, many genomically targeted treatments are being investigated, and we're hoping to uncover more as we start to sequence patients more regularly. It can uncover not only new treatment options, but reasons for resistance to treatments, as well as telling us which treatments may not be the best option and which might be. And it can help us inform the next therapy, as the case study that I had here. So I appreciate the opportunity to talk with you all about, I think, what's going to be the next stage of myeloma treatment, where we're taking all of the information we have, the clinical information, genomics information, and all of the treatments that we have, whether they're these blockbuster immunotherapies, which may be available to everybody, and these targeted therapies that go after specific mutations and specific groups of patients, combining them and hopefully finding the best sequence for patients, no pun intended. Thank you again. I'm happy to take any questions now or later.